Good afternoon. This is Joanne Conroy, and I'm here with Dr. Joe Perras, who's CEO and CMO at Mount Ascutney Hospital and Health Center, and he's our guest on DHH Facebook Live. So thanks for being here, Joe.
Thanks for having me.
So Joe has been at Mount Ascutney for how many years?
This is year 6, starting it.
Now you started as CMO, is that correct?
No, I started as director of their hospitalist program in inpatient services and medical director in care management.
What was it like your first day there? You had been working up here at
Yeah, I'd been at
Dartmouth-Hitchcock.
DH for over 12 years at that point. I go back to my interview day when I walked in and actually told the person that I was chatting with at Mount Ascutney it was the smallest healthcare facility I've ever been in. But I could have said that about every place I've worked. Even when I came to Dartmouth-Hitchcock, it was the smallest healthcare facility I'd ever been in. So it seemed like a natural progression. I noticed the friendliness, the smiles on everyone, the engagement every step of the way. It was a jarring change, but a good one.
Yeah. I can tell when I go into the facility, there's a real sense of family there. Mm-hmm. Everybody knows each other and they care about each other. Yep. And it is like a big family in one gigantic house.
Yes.
So talk a little bit about your background before you came to Dartmouth-Hitchcock.
Sure. I grew up in a small town in Dunstable, Massachusetts. It's called Dunstable, Massachusetts. Went to high school at Bishop Curtin High School in Nashua. Go Cardinals. And then went on to the George Washington University for both college and medical school.
Okay.
I went there for political science, thinking I would then pursue law school.
Uh-huh.
And that fell by the wayside after some early work in the sciences. I actually thought I would be a basic science researcher and spent time at NIH for about 18 months while I was in medical school, but missed patient care too much. Matched in an internal medicine residency back in Boston at Beth Israel Deaconess. Part of the first class of combined residents as we brought 2 hospitals together, Beth Israel and the Deaconess. That was interesting as far as cultural fit between 2 places, but we made it work.
It's the legendary.
Yeah, legendary for what to do and not do, I think. And met my wife there, who was a cardiac nurse. And again, because of my roots in New Hampshire, once I finished training, I knew I wanted to come back, and dragged her up, not quite kicking and screaming, but maybe some mild protest, and we've been here almost 19 years now.
Wow, that's great.
Yeah.
Now, what area of research were you initially interested in the NIH?
Yeah, I was in the lab of immune cell biology. We were looking at the way antigen-presenting cells hold on to the peptide. So basically, trying to rev up our immune system by changing the way our cells present peptides to other cells whose job it is to come in and do the work.
Now, is that kind of the precursor to the immunotherapy we're using in oncology now?
It was really a different wing. Instead of using site-directed antibodies, this was allowing the way our immune system currently works to function a little bit more efficiently, basically holding on to things a little tighter so the body has more time to recognize it and then fight the infection. I was the last group of researchers, I think, who had to look at pieces of film about 2 feet long with DNA sequencing and calling out A, T, C, G and making sure we're doing the right stuff. So it was interesting. I think a lot of the work that I was tasked to do is now done by computers.
Maybe a phone.
Exactly.
So one question about being at GW. Now, their claim to fame was actually Reagan was taken there after he was shot.
Yes.
And how long before or after your tenure there did that happen?
Oh, long before.
Okay.
Long before.
All right.
That was early 80s, and I wasn't there till 97.
Yeah, but it's a very different place than here in
the
Upper
Valley.
Valley.
Yep, absolutely. I went, as I was telling folks before we started, I went from an all-boys Catholic school in Nashua, New Hampshire to downtown Washington, D.C. Talk about a jarring change. It was different, but it was great. And I spent almost 9 years there. But was ready to get back to Boston, closer to family. and then back to New Hampshire.
Well, great. Well, we're glad you're here.
Yeah.
Talk a little bit about Mount Ascutney itself. It is like really a small kind of village, and the family that takes care of it on a day-to-day basis. Whenever I've gone there, I'm really impressed by that driveway.
Yeah.
That I think in the winter has got to be like a slip and slide.
Yes, our maintenance crew pulls people out of the snowbanks on the other side of our driveway pretty frequently. You're right in comparing it to a big family in a big house. We suffer the same things that most people have when they live in an old house. Sometimes our water doesn't work. Our electricity will go out. Last couple times it has been because of a squirrel falling into a transformer in downtown Windsor, and I'm not making that up. So we unfortunately have a good history with calling incident command pretty quickly and acting as we need to. You know, the thing that Ascutney is a big family. We know each other. A lot of folks are there's family members. You realize very quickly there are no secrets at Mount Ascutney Hospital, and that transparency, I think, is a good thing. Yeah. We're a very flat organization.
Yeah. How many people are employed there?
A little over 400.
Okay.
Yep. We have a very robust volunteer staff as well, and a very engaged auxiliary. You know, a story I often tell is around some of the work that my leadership team will do. We have we're small. If someone's out on vacation or someone's sick, it may not be someone to do the job. And in materials management, it's not uncommon to see my CFO helping to unload a truck, or my COO with a walkie-talkie directing traffic, and when we're out of electricity or water or what have you. That's what we all have to do. We all wear a lot of hats.
Yeah. Yes, I would say that is really obvious, that people are there just ready to pitch in and help in any way they can. Now I want to remind the audience that if you have any questions, just submit them through the news feed, and we'll get those questions and answer them within the course of our conversation. So when talk about some of the things at Mount Ascutney that kind of surprised you when you started working there full time that you didn't really appreciate through the interview process.
That's a good question. I think the level of commitment to the community was surprising, in the sense that, you know, I had worked at big academic hospitals almost my entire career that you know, largely referred to the smaller outside hospitals as, you know, OSH, outside hospital, or St. Elsewhere. It wasn't at the academic center, so we don't really know what goes on there. And I think we can underappreciate what happens at the community level. Our community health outreach is fantastic. We were able to tell a good story at the state level about all the investment we make in our community. I think that was probably the most eye-opening part of Mount Ascutney. And then the other part that I think is really unique is our acute rehabilitation center.
Which is beautiful. My cousin's husband spent some time there after he fell off a roof, which probably is not uncommon, but it is something we should aspire not to have happen. And they actually had a fabulous experience there. Yeah,
I believe there are only 2 acute rehab facilities that are actual units of critical access hospitals in the entire country.
Oh, wow.
And for us, we're the only accredited acute rehab facility in Vermont, and one of only a handful in New Hampshire. So to have those resources close by, I think is tremendous. We offer the closest physiatry, inpatient, outpatient physiatry resources for the system. We have a therapeutic pool, some gait retraining equipment that is unique.
How warm is a therapeutic pool? Do you know?
Oh gosh, I don't know. It's got to be in the 70s. I mean, people use it year-round, maybe 80. And that itself is a great resource. It's used all the time.
Yeah, people don't realize that if people are older, disabled, a little bit infirm, plopping them in even a 75-degree pool is actually a little bit of a shock to the system.
So I'm probably underestimating the heat. It's got to be warm.
Well, I think it's probably, I was actually went swimming in one this weekend, and it was great. It was like swimming laps in a bathtub, and it was 82 degrees.
Wow.
But it's a big difference from jumping in a 75-degree pool. So, well, great. Now, you have a separate director for the rehab facility.
I do.
And my recollection is she's been there quite a long time.
She has.
Hasn't she?
She has. I want to say 20 plus years. Her name is Belinda Needham Shropshire. She is a member of the senior leadership team, has directed our PT, OT, all of our therapies, as well as the rehab for many years. Vital member of the team. Now taking a larger system role because we are not the only rehabilitation facility in the system.
Yeah.
Down in Keene, at Cheshire Medical Center. There's acute rehab facilities as we move more into the southern region. We know that CMC also has an acute rehab, and we've started those conversations. So, you know, we have. I think it's a great example where a small community hospital, part of the system, can provide some real expertise to you know, the larger elements in the group.
Yeah, you really do. We do have a question from the audience. What advances in technology do you see driving better patient outcomes and also improving nursing and or clinical workflows? Because you have been described as kind of the learning laboratory for the rest of the system.
Yep.
So how would you answer that?
So I think the reflexive answer is we'll get onto EDH or EPIC in line probably in 2 to 3 years. We have worked with Cerner for the last 6. It's a mature EMR for us, does everything we need it to do. So we don't quite have the level of panic that some other hospitals have in regards to their EMR. What we've done in parallel to that is we've built up our telehealth resources. So we have tele-emergency services in our ED, and that helps both our providers, who are physician's assistants, and our nurses. So if someone sick comes into our ED, a trauma victim from 91, someone having a heart attack, someone having a stroke, there's a big red button. We call it the easy button. And you hit it, and a large screen TV pops up, and there's a board-certified emergency medicine doc or an ER nurse from the Connected Care Center here involved in the case from the get-go.
Okay. What type of cases do you get in your emergency room? Because you're close to some ski resorts, aren't you?
Yeah, we get everything. We have any number of codes, but it's bread and butter stuff, trauma from the highway, 91, as I said, myocardial infarctions, strokes, early sepsis. It's a 247 ER, has to be, because it's a critical access hospital, so we have to have that that capacity. So it's busy. It's always when I'm covering, I get paged, the code coming into the ER, unfortunate car accident, what have you, and we make do. But I'll tell you, it is reassuring to know that we've got telehealth support to help us. We also have telehealth in psychiatry as well. So it's cart-based, so there's a video cart with a psychiatrist on the other end that can help us manage patients in our ED or on the inpatient unit that need acute psychiatric care.
All right, that's wonderful. A lot of people might not know that you are more than the facility on, you know, the top of, you're off County Road. Yeah. But you have other facilities that are part of your kind of health network. Do you want to talk about those a little bit?
Sure. Sticking in Windsor, to start, we have an assisted living community called the Historic Homes of Runnymede, where we have about 50 clients, patients that live there. As I said, it's assisted living, multiple levels, folks that are pretty sick, just short of requiring nursing home care, to folks that are more mobile, and that has been a long-term commitment from Mount Ascutney to keep that care locally. We have the Ottaquechee Health Center in Woodstock with internal medicine docs, pediatricians, physical therapy as well, lab and radiology services, a very busy, bustling clinic right in Woodstock.
Yeah, that must be the major provider of healthcare to the people in that community.
It is. It is. Yeah. And then we have an ophthalmology practice in Hanover as well, which again is very busy also. And our ophthalmologist is Dr. Chris Connor, who worked here for quite a long time as well.
Oh, great. Now, you said that you had a lot of community physicians that actually participate in the hospital. That's it's less usual now that more and more people are actually being employed or integrated with the hospital. How far do you draw for community physicians? And I have to believe that there are probably a lot of solo practitioners that are still...
Well, I would say there were. Pretty much our entire medical staff now is our employed physicians. I think read the writing on the wall about the challenges of trying to stay in private or solo practice, especially in rural northern New England. Some folks still are able to do it. Primary care it can be a tough business.
Yeah.
So we've tried to create a model that I think is sustainable, especially considering Vermont and the environment that we practice in with One Care Vermont, our accountable care organization. So we're focused on providing high value care as much as we can, bending the cost curve at the same time focusing on quality. I think that's been one of the things I focused on more than anything else since I've been in a leadership role. Is around responding to the local healthcare environment and then trying to make it work in Vermont.
Yeah. We have a question from the audience. We've heard about a workforce shortage in healthcare. Is this also the case for smaller hospitals like Mount Ascutney?
It absolutely is, and we've had to be creative in how we respond to that. We've worked hard to approach what are market ranges on salaries so that we're not losing folks for $1 here and $1 there. We've invested in workforce housing. We had an old, like a lot of small hospitals, we have a campus, and we had a building that we were leasing out part-time to providers in the community. And when that lease ran out, we renovated it into 2 apartments so that we can provide housing. So that for this particular case, it was for a person, I believe it was a respiratory therapist, who lived beyond what we would call a reasonable distance to drive to come in on call. So now he can stay in an apartment over 3 days and do a power weekend of work and live right on campus. And we actually just closed on a condominium at the mountain at Mount Ascutney, a 3-bedroom place that we can then put families who are coming in from out of town. So we can supplement their rent, put them up for a few months until they get a lay of the land, figure out where they want to live. Because it can be daunting to move to a new community.
Yeah. Now, I think Windsor is actually a really charming town. You probably can't go many places in the town without people recognizing you. Is that correct?
Yeah, I think when I get my hair cut downtown, people will recognize me. I do try to pop in on Windsor sports, especially baseball, when they're playing. It is a great community, and most of our workforce is from Windsor, Heartland, also from Claremont and our surrounding towns, and folks are committed. Mount Ascutney Hospital, I call it the safety net hospital for Windsor County, really. We care for everyone, and that is our job, that is our mission. Our payer mix, the folks that come to our hospital, they're about 70% Medicare and Medicaid. That's our mission. Those are our people.
You can tell though when you walk in the facility how proud people are of the facility. And the facility, even though it's not the newest facility in the health system, is always clean and warm and welcoming. Talk about some of the things that your team actually does for the community, because I have a sense that there's a lot of community activities that occur either at the hospital or supported by employees.
So I have to mention the work of Jill Lord, who is our Director of Community Health. She is both a local, regional, and statewide legend for what she's able to accomplish. She brings stakeholders from all around the community together. She coordinates our response to our community health needs assessment that we just finished, and now we're working on implementing some of the changes that we need to do. It can be simple. I drop off lunches over the summer for our school lunch program. When school lets out, there's food insecurity for a lot of folks. So we pack bags and I deliver them to our both the school and the places in the summer where the kids are. It can be our community dinners that we host downtown. It can be any number of projects that we do around town as well. There's always something that myself or Jill are asking for. We never have a shortage of folks raising their hand to come in and do the work.
To help, And you have a great community that that people that have means do want to support
Absolutely.
the facility.
Yep.
Now we have one last question from the audience. What are some of the biggest advantages of being a part of the Dartmouth-Hitchcock system? And there may be some disadvantages too. I understand being part of something bigger, it sometimes is more complicated to get answers to questions than just answering them yourself. So you can talk about the pros and cons.
Yeah, I describe our journey as one that's had its bumps and bruises, some ups and downs, but overall overwhelmingly positive for the institution. To take a step back further, I think a small rural critical access hospital in northern New England, we all face existential questions. You don't have to look far to see hospitals that are really struggling. So I think that was a prime motivator for Mount Ascutney in entering the system. But we've worked hard to stay on message throughout this process that this is good for us. We have gained clinical services, whether that be gastroenterology, radiology. We've integrated our lab services. We provide better, more seamless care across the continuum than we did prior to the affiliation. We take 500 plus patients from Dartmouth-Hitchcock every year to our post-acute beds. That's great for us. It keeps us busy. It's great for Dartmouth-Hitchcock to create capacity.
Yeah.
We can go even to a more granular level and talk about the cost savings that it does. Being part of a larger organization allows us to get medications cheaper, to get lab supplies cheaper, to buy insurance cheaper. You name it. Those are the parts that patients don't think about, but those kind of cost savings allow us to invest in things that certainly don't generate revenue, somewhat like our community works and our community efforts.
It's interesting. I was struck by the focus on sustainable energy. And in my Joanne's journal last week, I highlighted the sheep and your solar field. So who came up with that idea? When did that happen?
So we've got a committed group of folks in a sustainability committee at Mount Ascutney Hospital. Our COO and our Paul Calandrella and our Director of Facilities, Joe Martinuke, who is married to my Director of HR, Jean Martinuke, work with...
Everybody's connected.
Exactly. Work with our sustainability committee headed by Mike Denmead, who's one of our a recreational therapists in our program. And we realized that we would cut our energy dependence, save a little bit of money, and frankly do the right thing by contracting with a firm to put a solar field in. And it has. We've saved money, and I think it's a great statement to make. The other part where we've actually really made significant changes is our work toward Energy Star certification. And only about a quarter of hospitals in the country have our level of certification at this point. And that was hard work. That was changing every bulb in the hospital. That was rewiring. That was changing the way we do things. And it's been a great journey. Now the sheep, people always ask about the sheep. So in our solar field, we have a flock of sheep. I'm sorry to say it's a different flock every summer. And every once in a while we have a jailbreak. And a real funny story I have to share is I think I was here for a day of meetings, and I got an email, and it was entitled Jailbreak. And this was not long after another semi-crisis that we were having to deal with. And at that time, the prison in Windsor was still open, and we border the prison. So I didn't have a chance to read the entire email. I just saw jailbreak. So I'm in the process of starting incident command once again, and my CFO, who is, as anyone can tell you, is a character, Dave Sandville. It was actually a joke because one of the sheep had broken out, and he had taken a picture of the sheep on the loose on campus, where I've been calling incident command because I thought we had a prisoner escapee. It was just a sheep, so it was funny.
Well, that's great.
I had my comeuppance. It was nice.
I'm sure everybody had a great laugh. Well, thank you, Joe. It's really great to hear more about you and hear more about the hospital. And Mount Ascutney is just a really important part of what we do as a health system, and I have to say it's an incredibly warm and welcoming facility. I see why patients and rehab patients and their families really remember their experiences there.
Well, great.
Yeah.
Thank you. It was great being here.
So thank you, everybody in the audience, for listening in, and we'll see you next month.